All right, welcome everyone. Oh, okay, we are recording. Very good. Um, Welcome to our coaching session. As a reminder, this is kind of just an open hour to have your questions answered or any concerns or comments in general. We're happy to answer them. So if anyone has a question, go ahead and you can either use the chat, you can speak up. You have full access to audio and so whatever works best for you. Okay, so kind of a quick question for the group. I am sending, I don't know if you saw my email earlier this week, but I'm sending out the survey or registration form for phase 2 of the collaborative, which will begin on March 17th. And I'm curious if anyone has some questions or concerns about participating in phase 2 or what that might look like. I'm happy to kind of walk that out a little bit more if you guys are interested in hearing about that. You see the question in the chat, can a new participant start at phase 2? That's, I think, a great question. I think as long as they're planning to participate and are planning to implement a QI project at the organization, I think that's completely fine. Now, we are limiting participation in phase 2 to those who are actually implementing a project because we want everyone to come to the sessions kind of on the same level, that they also are working through a project and really want to stimulate that sharing of successes and challenges and barriers. And so I think that that'll be much more effective if everyone in phase 2 is also working on a project. So that would kind of be our only stipulation for new participants to start at phase 2, but otherwise they are absolutely welcome.
Just to add on to that, Meredith, and a very good question, Greta. It would be most helpful if to that person who's joining, that new participant, like like your question addressed, if that person was able to review the previous session so that they could, as Meredith has said, come in on somewhat equal foundational ground as the others who have kind of grasped some of the concepts, since the phase two will be pretty much hit the ground running. I think it'll be moving pretty quickly, and there's more of a time for refinement rather than learning some of the QI kind of concepts. But certainly they could review those things before it starts.
Yeah, thanks for listening. And I kind of want to iterate that phase two is when we'll really kind of you start to get your hands dirty, so to speak. So you'll be diving into really how you actually do these improvements. So phase one was really about learning kind of the focus areas of pediatric readiness. It was really exploring sort of what that focus area looks like within your agency or fire department or ED, kind of the current state, identifying areas that you might improve. And then this phase two is really jumping in and really working towards those improvements and seeing how others are doing it and learning from each other on how to really approach this. So you'll get a lot of more of the examples and the how to go about this as we move through phase two. You know, part of the registration form has you list your aim. We have you put a SMART aim in if you have one developed, or you can check a box to say that you maybe need some more assistance with that. Identify your change strategies. Give us a few ideas of what you're going to be measuring so that we can really structure the content in phase two around your projects. But that's not to say that you need to come with all the answers to phase two. So having a general idea of what your project will be would be great. You're going to have through about February 20th to decide if you want to participate in phase two. So that will include a whole nother coaching session like this where you can come with your questions about phase two. But right now, you know, start thinking about if it's really for you, if you want, you know, to speak with your leadership, if you have the bandwidth to do it, all those sort of foundational elements, who might be on your team to assist you or who you might rely on a little bit as you go through this project. Then as a reminder, so for our physicians, you can get 25 MOC Part 4 credit points. And for nurses or anyone else, you can really use this as a clinical ladder project. And we are happy to support you in whatever documentation or forms or letters that you need from our end to really assist you in improving there. And phase two is open for our managers as well. So I want to reiterate that we will be working with you directly on working on a specific project. So not only will you be kind of maybe available as a resource to those that are implementing improvement projects at sort of the clinical level in your state or territory, but also we have a whole QI aspect for you as well, as whether it's, you know, recruitment of PECs or maintaining a network or hosting an educational conference or working at sort of the more regulatory level or pediatric medical recognition programs and getting the PEC position more recognized within your state or territory. So definitely a defined area for our EMSC programs as well. Any other questions on what phase two will look like, what we've done so far in phase one? This month, we're focusing on care team competencies. The recordings of that sessions went out on Monday. All of the recordings are up now and all of the slides. I got Dr. Arbach's slides this morning. And he sent me a few of the links to some of the simulation websites that he had mentioned during his talk. And so I put those under the resources for the focus area. So everything should be there for you to access and review if you need to. Yeah, it's well stated, Lewis, that you're really not expected to have really sharp, fine-tuned QI skills in phase 2. We're going to help you develop those. So, you know, come with an idea of a project and jump in, and then that's really what we want to help you with is really with the how to implement it, how to develop your aim statement, how to identify a change strategy, and how to monitor improvement. So I think it could be very useful. And it's only March through June is the official time frame, so it shouldn't be a ginormous time commitment. The structure is going to be relatively the same as this, except for we won't have the first hour of sort of that more lecture style. So it'll be more small breakout rooms where we're really exchanging ideas with each other and helping each other overcome barriers and solve problems. But the general layout of the time commitment is the same. So it'll be approximately an hour or so on the first Thursday of every month. And then on the third Thursday of each month, we'll have another office hours just like this where you can come and get additional assistance if needed. Jillian, you have a question on the topics on policies? Sure, go ahead.
Okay. Hi, thank you. Yeah, so I guess I'm seeking like feedback or if people have experience with this, but there was conversation at the facility that I work at within the emergency department of essentially eliminating all of our policies and moving toward just having I forget the exact phrase they were using, but basically just having standards of care in the place of them. And my initial response was I was horrified, but then I had to, so I took a step back and I was just quiet because I wanted to get more information and just like get some feelers out and talk to some people about, I guess, A, if there's experience with this, B, reasons for or against it. I have lots of against it. And also the impact, like, you know, on the care we're trying to provide for patients. And so I have some thoughts and feelings about it, but I'm really interested in the group's experience and feedback around this.
So this is Michelle. So from my experience, policies really should guide like laws and regulations by like governing bodies. In care practice or guidelines is more the hands-on patient care perspective, at least at our site.
Right. And so I took lots of notes from the policies and was really focused on that of, right, like what the purpose of a policy is versus, you know, the procedures and guidelines and things. Yeah. And so I feel armed and really empowered with that information. I'm really glad to have it. But I just wanted to feel out. I didn't get a good rationale for why they wanted to do it. But I wanted to be able to come back in the conversation and just make sure I was like talking to other people to see what other people were doing or if they were doing this and why, because what I learned in that and what my experience is exactly what you just said, right? And I think they serve a broader purpose. And so, yeah, I'm just curious what you all are thinking.
Yeah, I mean, I think you usually need a few policies that just are overriding and give guidance on like regulatory issues. There's certain regulations on like suicide and how to manage those types of patients that you have to follow. And then the more how-to is really in your clinical guidelines. And usually joint, like even if you're, I don't know if you guys are accredited by Joint Commission, but they usually in their regulations and guidelines, they have certain policies that they want to look at and see.
Yeah, we are accredited and we're also, you know, we're an EDAP and there's like things we need to have for that as well. But also the wording of our standards for EDAP says policies and procedures. And so again, like the interpretation of that, I'm pro policy, but I'm just, like I said, really just trying to make sure I'm not, being old school or like narrow-minded or anything in this.
So Jillian, this is Luis Gonzalez. I can't speak to hospitals like Michelle can. I speak more in terms of systems and organizations. So if I heard you correctly, that shift is more on the clinical or patient care side. Did I understand that correctly?
Yes, it's within a clinical setting, and they just were, I think part of what they were talking about was, the process in which policies have to be approved and updated and all those things. But I believe that there's other parties involved. It's like a system of checks and balances, right? If we just hand these things over to whoever is in leadership at that moment in time within the department, like these things could be changing and go unchecked and not necessarily reflect, best practice. And I just have concerns about that, I think.
Well, the other side of it, and so that's very helpful, is when you look at things from a systems perspective, and I mean systems within your specific institution. From a systems perspective, the role of policies, it sounds like you took good notes, and so you understand, kind of that role, but from a systems level, the policy provides kind of the general, this is how we do things at institution X, and provides that the general kind of, I hate to use the word direction, but kind of this is how we do things here, which is really culture at that particular institution, and not so much the how. And it's really more for systems that are, I shouldn't say it's more, you can certainly still apply it for those systems that are non-clinical. Like if you look at equipment or how that works, you could certainly still have policies that work on that are not necessarily clinical. That's why I asked the first question. But the clinical side, yes, I understand there's lots of changes that are going on at different institutions, but you could look at the other systems that are direct patient care kind of policy related, and there's certainly still an avenue for that if your institution still is okay with policies, period.
I think if I may,
Go ahead.
I was going to say, if I may add as well, absolutely, an emergency department is a clinical department and a clinical program, but it is still part of exactly what Lewis is saying, that ecosystem of the hospital. And so recognizing that even though an emergency department is very clinical focused, it is supported by many non-clinical systems and non-clinical processes in order to have these clinical standards of practice be carried out, and for it all to flow and also to be linked together. And so I hear you when you say, perhaps on the clinical side, wanting to remove the policy aspect of it, but there certainly needs to be a bridge that connects the clinical to the non-clinical, whether it's administrative or whether it's that support side.
And I think remembering that clinical guideline doesn't mean you don't have to follow it. It just gives that little bit of wiggle room for providers if something is in between two different guidelines, or they're not sure and they're trying to figure out what the patient has going on. But like even IV management, it's a clinical guideline, but it still should be followed by staff. And if there's evidence to support changes of it, you can look at that and just have the same processes for policies. How often do you review them? And what group reviews them? And what does that process look like?
Thanks. I really appreciate all of that information and feedback. I just, like I said, really wanted to make sure I'm not like completely just out of the loop on, things as they change. And that I was understanding the information that we went over last month. So thanks, I really appreciate that.
Does anybody else have questions about policies or even any of the other content we already presented earlier? Or any thoughts on any of it?
I see Gabrielle's question is see if you could access template slides before each session, so you could work on drafts as you're attending the breakouts and work on developing the project. I'm assuming that's for phase 2 you're talking about, or are you talking about like the last 2 focus areas that we have? Yeah, phase 2. Okay, perfect. Yeah, no, so at the first of every month, or even maybe immediately following the learning session each of the previous month, we will send you those slide templates. And the idea is to be that you would kind of fill those slide templates out. So for instance, you know, month 1 will probably be pretty simple. It'll be like, this is my team or who is helping me. And you can, you know, list those members. And then, you know, the bottom half of the slide might be your aim. Now it could be a global aim. Ideally, it's a SMART aim, but we can help you get there. But the idea being that you'll have that coming into the learning sessions. So then as a group, as we're discussing examples or how we can talk about how to improve there, you'll have that ready to go and we can share it with the group. And so you will have that ready to go if you want to speak up and share your experience. Hopefully we'll get enough repertoire between the whole group that you'll feel comfortable doing that. I'm also going to have you submit it through REDCap, and then I can show them anonymously. So, and then we can work through them as an example. And I'll even have maybe a checkbox where you can say, yes, you know, please use this as an example, but don't let anyone know it's mine. And then we can work through your slide template, really look at your SMART aims and really how we can improve it or tweak it or give you any coaching or suggestions beyond that. So yes, ideally you'll have those slide templates and ready to share, and we can make them perfect. We can talk about sort of some of the options for projects that we are looking at through phase 2. So let me see what the best show that to you is if you want.
I think somebody asked Meredith about what type of policies are there to create, and I referred them to the NPRP toolkits and gave the link because it does tell you for PEDS readiness.
Yeah, we do in the toolkit have suggested policies that would be good. And you can go back to our learning session or even that focus area guide, and that hopefully have a little more direction too on what kind of policy you can look at. And really the idea is to kind of talk to others at your institution, see what's important, see what, you know, their biggest concern is. Like maybe you need one around safe transport or use of restraints or kind of
Yeah.
what you see as the biggest problem, right, Michelle? What would you say?
Yeah, look and see, what's good to do is look and see what do you have guidelines or policies for, and where do you see gaps in what you currently have for safety, for quality, for care of patients. Or if you're just having gaps in your pediatric patients, is there something you can add to those rather than recreating new? Or is it something you need to create a specific policy or guideline for?
Yeah. Sometimes it might be helpful to, what we kind of do is just conduct this sort of baseline assessment, really, where you can maybe look at a couple of your, or a few of your previous pediatric runs or patients encounters, and what went well, where could you, even maybe ones that resulted in a safety issue or something that, your staff maybe felt uncomfortable with, and say, okay, maybe we can develop a policy on really how to go about this or not. Kind of the easy ones there that we've worked on through the pediatric readiness quality collaborative. I wouldn't say they're easy, but maybe simple, but most highly effective are things like weighing all children in kilograms only, or developing a policy for the recognition and triage of abnormal vital signs and how you go about that notification process. Or I think those are kind of, that's not condition specific. It really would hit pretty much every pediatric patient that you encounter, and really where you can make a lot of improvement in the quality of care for those kids.
Yeah, those are great examples, Meredith.
Pull up. No, Maggie, that's a good one. I'm wondering what the group has. Any suggestions on policies regarding parents riding in the back of the ambulance on the critical piece? I'll let my pre-hospital folks jump in here. Lewis, Rachel. I don't know if Rachel's here.
Well, I can jump into what could be quicksand. Maggie, I think you raised a really good question. Is what you're seeking example policies, or just kind of the pros and cons kind of discussion? Because I'm not sure there's a simple answer to that. Are you looking for suggested policies? I only know, and actually, I think what you find from my experience in, well, the last 29 years with EMS is many don't create a policy. It's more an unwritten kind of standard. The wise ones probably do have a policy. It's just very difficult because, as you know, it's so situational. But as we know, for children who are awake and aware, it's already pretty scary for them. It's a stressful environment, and so having someone that they can relate to with them makes them. It helps with the care, as you know. The downside, though, from the administrative side is always the concern about risk. And so that's why it becomes really a kind of a local situation based on the degree of risk that the organization is willing to take on. So, there are suggestions you can make in a policy, like if the child meets these kinds of criteria, meaning that they would benefit from the parent being there, then it makes a lot of sense to have in your policy that they can do that, as long as they're able to be safely secured, meaning the parent can be safely secured in a seat, and there's room for them. But if they don't have a benefit, then then the risk manager at your organization might say, why do it? You know, so there's just lots of nuances to it in the EMS setting, but it's mostly geared around or stems from the risk concerns. And I see Jen is kind of right there with me in that, you know, often it's an unwritten kind of policy kind of thing. I think there's some advantages personally to having that policy, because in that policy, while you could still have lots of that wiggle room, you could maybe, I don't advise wiggle room for unsecured parents in the back of an ambulance. That's not a safe practice. I know medics may be unsecured, providing care, but for family members and other riders in the back, really should be secured, just because we know that one of the riskiest things that EMS practitioners do is just being on the streets in a moving ambulance. So risky for everyone. So let's try to protect the child and the parent as much as we can. So I know I didn't help you with that. I could, if you like, who was Maggie? I can certainly check around with a couple of my local agencies, which are big organizations, and see if someone has written one since I left them, and reach out to you. If you'd like, I can certainly do that. I'll put my email address in the chat box, and you can let me know.
And Rachel put also an example in there.
Is that transport of the child?
Safe transport guidelines. Yeah, Rachel, I think added that.
Yeah, and I think is that more for the child or the parent?
I am not sure.
I haven't read those. So there's no question, there's some great guidelines for the child, and make perfect sense for the child, for there to be a policy for child protection during transport. The parent one's a little bit harder, if I understood Maggie's question correctly. And it's a question that's been dealt with by EMS agencies for a while.
Meredith, I see your question in the chat box, and I think that's a phenomenal question. And yes, we would absolutely encourage interdisciplinary teams that include both physicians and nurses kind of working at the same project within the same organization. That would, from our experience with QI collaboratives, we know that makes a project that much more effective, and have a higher chance of succeeding if you really have these multidisciplinary teams that are collaborating to really drive forward that improvement. So we would 100% encourage it. We obviously don't want to mandate it because it's not a reality for a lot of us, but I think that would be great, and we'd love to have them work together. Yeah, I can absolutely do that. And I'm trying right now to kind of put a couple of slides together so I can show you more fluently what phase 2 will look like. But in the meantime, we can run through some more questions. Your question too, Gabrielle, to piggyback on the question, your medical director is in the physician group for the collaborative. And I would strongly encourage you to work together on an initiative project for phase 2. Absolutely, I think so. But you don't necessarily have to. Like I said, we encourage it and we think it could be that much more effective if you work as a team. But if that's maybe not your reality, you certainly do not have to. If they are also participating, you can do your own projects, but we would certainly encourage you to work together. Trying to pull this up for you guys. So. Okay, I promise I'll have this a little prettier by the time we get to talking more in depth about phase 2 at the February learning session. But I wanted to show you guys. So let's make sure I have the chat box up so you can see it. So you will be able to choose from 4 areas for a project, and that being sort of the PEC role, equipment, supplies, or medications, policies or procedures, and then care team competencies. And I think kind of the best place to start as you're thinking about a project or what you might want to do to improve is really these process flow maps that were included in the presentations, and they're also in all the focus area guides. And this is really how you can kind of walk through what it currently exists and maybe help you identify some of your gaps. So if we take sort of the PEC role as an example, you can look, okay, does your organization have a PEC? No, we don't even have a PEC. So let's start there. And then from this flow map, we suggest change strategies, and that's if you go into the focus area guide. So for instance, here's the policies and procedures focus area guide. You work through this, and then each of these change strategies has its own key driver diagram. So if you come down here, in a way, so let's see, we need to raise awareness of kind of the importance of a PEC. So one of the ways you could go about that is really garnering leadership support. So, and this is not the aligned right focus area guide for the PEC role, but really kind of advocating for the role of the PEC and how are you going to go about that? And there are some tools, and I think Michelle and Rachel have been dropping these in the chat box of the National Pediatric Readiness Project Toolkit and the Pre-Hospital Pediatric Readiness Project Toolkit, all as well as at the very end of these focus area guides, all have tools to help you do that. Oops, this is not the right button. Where did it go? So there's tools and resources down here at the end of every focus area guide that takes you to, for instance, template elevator pitches, or not going to work because we're not on the same one here, but for instance, this one around policies and procedures, you can see that we have some sample policies, we have example and pre-arrival instructions, so you can kind of use that to really start to build your project. And so ideally, and if you have been kind of working through this environmental scan worksheet each month, that was really the idea behind this environmental scan worksheet, is to kind of help you work through that or decide what your project might be for phase 2. So as you work through, maybe we want to do a policy and procedure. So is there a standard format? Like, how do I go about really doing this? How do I go about developing a policy that I want to? And so these are kind of the things you would work through, and identifying areas that you could really do or change or improve there. And then when you begin to think about how you're going to measure change, or how you're really going to know that the change you make is leads to improvement, that's when you can also come back through there and start thinking about ideas on measurement. And we're going to help you kind of pick out some measures too as we work through this. I think I could throw up a slide of sort of the IHI model for improvement, and we'll go over this in our final learning session in March, but I to show you kind of the foundation of phase 2. Give me a minute to pull that up. In the meantime, anyone, you're welcome to jump in with questions or maybe ideas you have for what your project's going to look like, and bounce them off the group. That's kind of why we have a lot of our experts on the call who can kind of help you work through some ideas on what you're thinking about doing. Does anyone really have an idea? You can even just use the like raise hand feature if you already know maybe about the area you're going to work on.
Hey, Meredith, if I might, and I'm sorry, folks, to join the call a little bit late, but if I could just add a few comments around this work, these 4 areas of focus were really chosen strategically as areas that we knew one were of interest, but that started with some simple aspects of readiness and kind of moving into more complex areas of system improvement. So really, the focus within, an organization that chooses to say we want to, focus on establishing the PEC role. A lot of this will be on really garnering support within your organization for why this is important. And there'll be a lot of opportunities to work collaboratively with others to really kind of reframe the elevator pitch, revise it to really fit the culture of your organization, identify ways that you can do this to really try to enhance awareness within your organization's leadership and among other colleagues of the value of pediatric readiness and the work that we do. And we found a lot of times in the past there's individuals who are more or less serving in this role, but their work is almost gone unnoticed, or the value or potential impact of their work on actually improving care, decreasing risk, and adding value to an organization. So that's really what the focus is of that. And I would say, if you choose that particular area, there will be, of course, collaboration across organizations, but if you do have the ability to work collaboratively with your medical director or another staff member, by all means, you should go ahead and do so. And I think there is really a powerful dyad that's represented within the PEDS Ready guidelines, which is that it takes, on the hospital side, physicians and nurses working together. And I think on the EMS side, a medical director and the frontline providers working collaboratively. So I think that's very powerful, and the influence that you have across the organization will be greater because of that. The next one that we really tried to identify for equipment and supplies was this was the next kind of easy step up, is there are very clear national guidelines on what equipment, supplies, and medications should be in place in every single ED and EMS agency, regardless of your size, scope, resources. So this is really a nice initial kind of quality improvement step. If you've already got support from your organization and the leadership that's saying, yeah, we think pediatric readiness is really important, this is the first step that we might take, is just making sure we have all the necessary equipment and supplies in place. And so this is a little bit more structured as well, because this is intended to be kind of a one size fits all in terms of what equipment, supplies, and medications you should have, and then how we develop processes to sustain that. And that, of course, is going to be slightly variable based on the individuals and resources that you're working with, but establishing and ensuring maintenance of those equipment, supplies, and medications, that they're easily accessible and available to staff, is a really nice kind of first initial quality improvement project to really dive in and to impact clinical care. I think the third one on policies, procedures, and protocols is really kind of even that next step up, because there are some, national clinical care guidelines or recommendations when it comes to evidence-based care, but it's a little bit difficult to sometimes figure out exactly how that fits within the scope of our organization based on either the equipment and supplies that we have available, or based on the scope of practice, based on the resources that we have within our EMS agency or hospital. And so this is really a chance to kind of take that evidence base and morph it into a setting in which we work, and to implement it to make it as effective as possible. We know that this is a high level of interest for folks, and one that a lot of people don't have a lot of experience with, of how do I actually write a policy or procedure and implement that into practice and roll that out so it has a high level of adoption. And I think, if we look back on all of these, it requires buy-in, and it requires buy-in from other staff and buy-in from leadership. And so, building on this first conceptual framework of, the PEC role and establishing prioritization of pediatric readiness within your organization, that is an underpinning of every single quality improvement effort, is having the buy-in and the team building on the front end to be able to do that. So if you're thinking about establishing a policy and procedure, it's not necessarily what you want or what you're most interested in, but it's based on either the needs within your organization, maybe sentinel events that have existed, safety issues that you've identified, or maybe it's an interest that's come from, the medical director or the leadership within your organization to say, man, we really need to develop a policy on pain management so that we can help to standardize that. And then I think the last piece is the care team competencies, which can maybe be a little bit more challenging or complex to implement because it is external to the day-to-day care pathways and processes, but it complements that well. And this is one where we start to look at, do we need, simulation, whether it be low fidelity, high fidelity, or are we just walking through mock codes, or how are we starting to establish some of our care team competencies? So I just wanted to walk that out a little bit. And then, to the comment in the chat box, which is we should use the structure of the environmental scan worksheet to really work out resources needed for the project. The idea of the environmental scan is to identify where the gaps might be so that you can choose an area of focus, so that you can actually target that as your primary focus over the coming 3 months. And yes, we will be sharing tools and how to measure change. And our plan is to really walk each of you through these projects, starting with, okay, let's figure out what we're trying to accomplish, what's our global purpose, then developing a SMART aim, identifying those gaps, walking through some potential change strategies that you might choose based on the resources at hand, and then being able to implement that and measure your improvements over time. So we will be walking you through each of those, and you'll learn so much, I think, from each other as you do that, and depending on your area of focus. So sorry, I know that's a lot, but I just wanted to walk that out a little bit and reiterate it for everyone. And Meredith, we can see your eye turn, madam, now.
Yeah, I was trying to trying to get off mute so that I could explain that, but I couldn't find my controls. I found them. So kind of just piggybacking off what Kate had just said, this kind of gives a visual of how we were going to do this through phase 2. And it's really kind of just structured exactly what you just said. So you're really going to start here with what do you want to do? What are you trying to accomplish? And then that's where we'll work with you to develop a SMART aim to really get specific about what you're trying to accomplish. And then we'll walk through, how will you know that a change is an improvement? And this is where you'll get to, like, what are you going to look at? What are you going to measure so that you know that if you implement a certain change strategy, that it's actually working towards your goal, working towards your aim. And then the third question of the IHA model for improvement is, okay, what change can we make? And as I mentioned, we put some suggestions in a focus area guide. There is plenty of resources online in the toolkits that have been shared in the chat, as well as we can help you think through that a little bit, and what resources do you have, and what might be a great change strategy to use. And then we'll jump into what we call PDSA cycles, or plan, do, study, act cycles, where you're going to implement that change. So you're going to think about how you're going to implement it. That's the planning aspect. You're going to implement the change. So I think the example we always give is maybe the one of weighing all children in kilograms only, and this would be an ED example. And so, that's your goal. You want to weigh every child that walks in through the door in kilograms only. And how are we going to know that this is an improvement? Well, we're going to record how many kids were weighed in kilograms and how many were weighed in pounds. And we're going to see, hopefully, that the percentage weighed in kilograms over time is more. And that's what we're going to look at. So what change can we make? So we could buy scales that lock in kilograms only. We're going to lock them in kilograms. And that's going to help. We're first going to do it. So we get that in every room or everywhere that we have scales. and let it go for maybe 30 pediatric patients. And then we're going to look at that, and we're going to look at the proportion of pediatric patients that were weighed in kilograms only, and decide what to do. So maybe that did it for us. Maybe we're now weighing 100% of kids in kilograms only. So we accomplished our aim, and that was great. Or maybe you're not. So maybe you need so then you come back here. Okay, so what next change can we make? And like I said, this is going to be the topic of our March 3rd learning session. We're really going to dive deep into this, but this high level of what phase 2 will look like is we're going to walk through this. Okay, so you tried this, and as a group, we're going to talk about, okay, so what went well, and how well did you improve, and what do you think you could do next? All right, maybe we need to put posters in the rooms, in all the rooms, reminding everyone to weigh in kilograms only, and then do another 30 pediatric patients and see how well that improved you. What percentage of kids are weighed in kilograms only now? And so you can kind of keep working through this until you reach your aim of we want 100% of pediatric patients weighed in kilograms only. Catherine, just quickly are able to share these slides. I'm going to get them ready. I can share these slides fairly immediately, Catherine. I'm happy to. I'll post them to the website, or I'll email them to you so you can take them and do whatever you like with them. Yeah, of course. And I'll show you where I'll post them here. If we go to, hopefully you guys know this exists and you've been here, but if you come to our EIC website, QI Collaboratives, PEC Workforce Development Collaborative, every session has the slides, the recordings. You get the slides here, the recordings, focus area guides, environmental scan worksheet. You can go explore the focus area more. You can see those flow diagrams that I posted. You can come back and look at all the different focus areas. So that'll all be here. I will do that under today's coaching session. I'll throw these slides up so that you can come back. I don't even have the link up here right now, but I will put it right here. So you can come here and access it too. I don't think you're the only one, Catherine, by the way. I think that's probably my most frequently asked question by email is where are the recordings, where are the slides? They're here on the website. You can access everything and you don't need a password or anything. They're completely publicly accessible. Let me put this here. I'm just going to drop this in the chat so you can all get to it right now if you want. Thank you, Betsy. That's appreciated. I guess in the last 4 or 5 minutes, I put this in this week's email, but I wanted to make sure that you all were aware too that there is a trauma improvement sprint coming up. It'll be 2 half days, February 23rd and March 2nd. And this is really designed for trauma centers to meet the new ACSCOT verification guidelines around pediatric readiness. What it'll essentially be is this collaborative really condensed into 2 half days. And then those participants will be invited to jump in with a QI project for phase 2 as well. So if you're a trauma center or you work closely with a trauma coordinator at another trauma center, please share this with them. It's here on the website as well. We're calling it our trauma improvement sprint. Registration has been open. It'll close, I think, February 20th. That'll give us enough time, 3 days, to really kind of make sure that we are fully prepared for the half day on February 23rd. But another option, or if maybe you've missed a lot of the sessions and you want to come here, so it'll have definitely more of the examples will be more trauma in nature, but not completely, because trauma centers, pediatric readiness is still a foundation for trauma centers regardless of whether it's a trauma patient or not. So another option, I think, just to be aware of. What else could I show you guys in the last few minutes? Latest news, I try to post every newsletter that I send out through Constant Contact up here so that you can access them. Oops. Because I know that some of my emails that come through Constant Contact are blocked by hospital systems. So any last questions or comments, thoughts? Feel free to email me. I can put our email, PWDC at MSC Improvement Center. If you have any other questions or comments, if not, we'll see you all on February 2nd. And be looking for the registration form for phase 2. It should be coming out later this afternoon. Thank you all, appreciate it.